I'm going to be talking about a project that started in my lab almost 4 years ago when we started looking at modeling or applying organ-on-chip philosophy to create a design of a vein on a chip so that we can model blood clotting. And when COVID-19 hit, we were in a position to think how we can purpose this study to look at COVID-19 induced thrombosis. So over the next few minutes, I'm going to just take you through the device and some of the results that we acquired with this chip, and then tell you a little bit about what we are doing in terms of modeling and characterizing COVID-19 induced thrombosis using this platform. All right, so I think by now most of you can appreciate the fact, because it's all over the news, that what differentiates between survivors and non-survivors due to COVID-19, the one differentiating factor or the key differentiating factor is that the non-survivors of COVID-19 had something to do with blood clotting. Okay, and within the domain of blood clotting, almost, and it depends on which literature you're referring to or where the publication is coming from, but loosely speaking, there's a significant amount of evidence that suggests that a large number of patients who suffered from blood clotting due to COVID-19 had those blood clots in the vein, or DVT as we now see. So the burden of thrombosis in COVID-19 is huge. When we got started with creating the vein chip or a model of vein thrombosis, one thing that we learned very quickly was that it's not just about creating a new technology. The reason for creating this technology, or the need why we need to have a vein chip or a platform of organ-on-chip, is simply because the murine models are deficient. And it's not just that we are saying, the people who work with mouse models themselves confess that the mouse models of venous thrombosis are deficient. And there are many models, as you can see on the top right, but none of them really recapitulates some of the physiology or the critical physiology, particularly as it relates to the venous hemodynamics or hemodynamics-induced blood clotting, is modeled appropriately. What you see over there is actually, in a nutshell, is arterial thrombosis being modeled in a vein. So all mouse models of venous thrombosis are essentially creating a stenosis in a vein, and so the thrombus forms in the vein, so they call it a model of DVT. But really the nature of the thrombus that forms within that vein in a mouse is arterial in nature. And I'll tell you what is so unique about venous thrombosis and why there is a need to model venous thrombosis appropriately in its context of architecture of the vein, as well as recapitulating venous hemodynamics much more accurately. Okay, here we go. So this is a very old picture, more than 100 years old. Some of the first publications when people started looking at what veins are and how do they look. So veins contain valves, okay? So the heart does a very good job in pumping the blood through the arteries and providing oxygen to the tissues, but it leaves a job for the blood to come back to the veins. It doesn't do that job itself. So the veins have the responsibility to bring back the blood to the heart, and it does so by having these structures which are called veins. These are nothing but muscle pumps, okay? So the vein valves work like pumps that keep pumping the blood back towards the heart once the blood passes through the arteries into the organs and has to return back. So they contain these architectural structures that we call them valves. Now, venous thrombosis is a disease where a blood clot forms, but it is now known also for almost a century that the thrombosis in the vein actually starts or gets initiated within those valves. Okay, this was an observation that was made 100 years ago, and till date these observations hold, that venous thrombosis initiates at the site of the venous valves. Okay, so you see this architecture of the valve, and you see that the thrombus sits there first. It is from here that the thrombus actually breaks, goes to other parts of your body, for example, lungs, and then clots the lung, which we call it as venous thromboembolism. Okay, but this is the site of thrombosis. So just to give you an idea, when we entered the field, I don't think this slide needs to be shown to you, because I think you all appreciate why we are here and why we do and why we apply organs on chip into problems like this. Just to bring organ on chip to context, I like to now use the term physiology on chip rather than organ on chip, because what we are really trying to do is not mimic an organ, but to really mimic the physiology, which is much more relevant in what we all do. Okay. So the question that we asked was, if we were to try to recapitulate or learn anything about venous thrombosis that is already not known through the mouse models, is organ on a chip an option? So before I started this project, I was a postdoc in Don Ingber's lab, and I created the thrombosis on chip platform in his lab in a different context, in a vascular bed or in an arteriolar type topologies, but never in a venous type topology. So we asked this question: can we sort of now take what we have learned and now apply it to create a vein chip? Okay, so some of the first things that we do was to create the topology or the architecture of the vein. So we took borrowed images from OCTs and other clinical images that were published in literature, and we mapped the contours. We miniaturized it to a size which is a mouse scale, and we created these devices that you all know that we use through PDMS structures to create the architecture of a typical vein. Now this is a pathological vein. Why? Because you see that the vein valves or the valve structures that we create are static. I'll show you in the end that now we are also creating healthy veins, but this is a model of a dysfunctional vein where the valves have become incompetent. And very, very often when you have DVT or thrombosis in the vein, the valves become incompetent. Okay, so this is an incompetent, non-moving valve and a vein chip, but still consisting the architecture of the vein, and that is conserved. Before we started to actually do any kind of cell culture or create living vein on a chip and perfusing blood through it, we did some computational modeling to see or to judge whether the flow that we predict in these structures would have anything or any similarity to what is observed clinically. So we applied a computational model in the very beginning, and we actually found that we applied the computational model, and we found that what happens is that when you perfuse blood through it, there's a very unique flow pattern. It's basically two counter-rotating vortices that you see in the cusp region. And we predicted it computationally, and when we perfused whole blood, we again saw those two counter-rotating vortices in these cusps. So if you apply, a model where you mimic blood as a non-Newtonian fluid and applies proper constitutive equations of viscosity, you would actually see that indeed blood has counter-rotating vortices, which we can also validate experimentally and has been shown clinically as well. So this was the first proof of concept that indeed, if we were to create an architecture like this, we could create venous hemodynamic states that are unique to the vein, which you cannot produce when you do stenosis-like modeling in a mouse model, where you can create changes in flow that is important in creating clots, but this flow structure and the clot that forms due to its structure is unique, and which I will show you again. So once we were able to perfuse blood through this, the next task was to actually endothelialize it. So when I started this project, and this was a very complex geometry, I was actually very skeptical that we will ever be able to practically endothelialize complex structure. But it so happens that we were able to do it quite soon within a very short amount of time. And this goes back again to the philosophy that if you give the cells the right environment, they would do the job of self-aligning themselves. So what you see in this video is basically endothelial cells that were seated within the vein chip. The entire imaging is done within an incubator, and each image frame is about 2 hours apart. So over a period of about 18 hours, what you see is that these endothelial cells that were initially seated are getting confluent within the vein chip. And in fact, it's not just in 2D, it's actually in 3D. We can actually create an endothelialized vein chip in my lab. So the barrier function is competent in the valves itself, and we check that. So now what we were able to create is a model of a vein chip which is endothelialized, which has the architecture of the cusp, and you can perfuse whole blood through it. What that means is that now that you have the three components, the hemodynamics, the endothelium, as well as the blood and the blood constituents, you can think about now creating disturbances within the system so that you can induce clotting. And then we have to check whether indeed now that you have a DVT that forms within the cusp or not. So we would do exactly like that. And indeed what we find is that you can form these cusps. But what also happened in this system, and this happened by serendipity, was that we found that even though this vein chip had the incompetent valve, when we were to perfuse blood without creating any stimulation, it would not clot in the cusp. Now, I showed you that we have these counter-rotating vortices within the vein, in the valve site. But we don't clot all the time. We need more than just hemodynamics or these counter-rotating vortices to induce clot. But those vortices, if you were to create them in a straight channel, or you create those shear stress conditions in a straight channel, you would actually rupture the endothelium and form the clot. So what is it and why is it that you don't see clots despite those rotating vortices? And what we learned was that during the time when we were culturing or making the vein chip, the endothelium within the cusp actually adapts to that flow. It knows already that these counter-rotating vortices are trying to make it activated, so it has to do something or conserve its anticoagulant properties to prevent itself from being activated. So what we saw was that there was a heterogeneous endothelial function within the vein chip, where within the main lumen you would have nitric oxide expression and procoagulant factor expression, which is close to normal, but within the cusp it was even further conserved. You had high nitric oxide production, reduced von Willebrand factor. What that means is that the endothelium became anticoagulant so that it can counterbalance the counter-rotating vortices that actually pass through those cusps. Now, is that real? We didn't know that. But what happened around the same time when we actually saw those results was a paper that came out from Michigan. And this was a clinical study where they were looking at the cadavers of veins, and they reported clinically that the endothelium in the cusps, in fact, is more anticoagulant than the total vein. So this was the first time, actually, and we were not actually expecting that to happen, that what we saw in the vein chip was actually clinically relevant or got validated clinically. Now, you cannot have this result in a mouse model, and there has not been any reproduction of this kind of a result in a murine model. Okay, so this was the first time we were able to see that indeed, not just in an organ-on-a-chip platform, you have cell culture, but you also have heterogeneity of endothelial function, just by changing the architecture of that. So architecture-dependent heterogeneity of endothelial function is something that we learned from this system. So now we were ready to start looking at thrombosis. And we did exactly that. Now, I won't go into the details. This is published in the journal Small. But around 80 or 90 years ago, one of the most prominent physicians of the time, by the last name of Virchow, actually philosophically introduced this paradigm that venous thrombosis is influenced by three independent factors or collaborative factors. One is the endothelium or the endothelial function. The other is the blood chemistry, the components of the blood, and how they influence venous thrombosis. And the third is flow. So all of these three factors can influence either independently or collaboratively to create a venous thrombosis. You can disturb either the flow or the endothelium or the blood or 2 out of 3 or all 3 to create venous thrombosis. But there has never been a modeling technique that could dissect or really tell us or teach us the independent contributions of each of these factors in creating DVT. Now we had this vein chip where we had the opportunity to change flow independent of chemistry and endothelium. We had the opportunity to change endothelial properties or its status and look at how it could influence thrombosis as well as the blood chemistry. And we could do that in a relevant architecture. So we did exactly that, and we found that when you perturb either of these factors or 2 out of these factors or all 3 of these factors, indeed you can create a DVT environment and you can actually produce thrombus formation within the cusp. And these data actually show that. So I'm not going to go and describe you all of the data. I'll give you just one snapshot or to tell you how one of those factors, which is the blood chemistry, influenced DVT formation. Okay, it's not just me that's sleepy. Okay, so this is the experiment that we did. The experiment that we did was actually opposite of introducing thrombosis when we introduced blood. What we did was we first perturbed the endothelium to create a model of vein thrombosis, and the thrombus was formed, as you can see in pink in these pictures within the cusp. And then we systematically introduced dose-dependent amounts of different anticoagulants and antiplatelet agents to see how the thrombus will be reduced or resolved. That would teach us how the blood chemistry would influence venous thrombosis and how different anticoagulants or antiplatelet agents would influence DVT. The idea behind this experimental plan was that in patients, and we talked to several clinicians who would tell us that clinical dose of anticoagulation does not resolve DVT in a majority of the patients. So almost half of the patients, when you stop the anticoagulation, some form of DVT still reoccurs. So why is that? We do not know. But we hypothesized that just like in cancer, if you provide clinical dose of an anticoagulant, it may resolve the clotting in the vein, but there could be some residual endothelial dysfunction or the blood clot that may still be within the cusp because it's a transport limitation and because of the unique hemodynamics that occur in that cusp. So we wanted to see that. So we introduced a variety of clinical anticoagulants and antiplatelet agents, and we saw that even though you could resolve the clot within the total vein, you would almost always leave out some amount of residual thrombosis within the cusp. So what we did was we created a possible clinical scenario where you would introduce anticoagulants and you would still have residual clots that could reoccur. Okay, so this still needs to be validated clinically, but that shows that clinical dose of anticoagulation would not resolve clotting. You can obviously increase the dose, okay, and resolve the full clot, but increasing the dose is a double-edged sword as introduction of more anticoagulant would result in bleeding in a patient. So the clinician has to make a decision as to how much anticoagulant or which anticoagulant to give to the patient so that they can resolve DVT but prevent bleeding. So this is a model that can be used to test anticoagulant and anticoagulant dosing that could then go and be tested in other modeling systems or in clinic. Okay, so this is an example of how we do it. We also now can look at other kinds of unique anticoagulants, for example, antithrombolytics, where you can form a thrombus first and then you can see how it gets resolved. So this is an actual picture of thrombus that forms in the cusp. And I'm not sure if the video will run or not. But what you would have seen in this video, do you think you can play the video? Is there a play button? Okay, so this is, no, the video is not running. So what you would have seen if this video would have run is that we are introducing again anticoagulant, and we are showing is that when you increase the dose of an anticoagulant, then and only then you would resolve the clot, otherwise it would not get resolved. So it gives you a glimpse or a picture of what might be happening inside a patient vein. Okay, so now we have a model where you could dissect Virchow's triad. You've shown that there is some validation with the clinic, and now we want to see if we can produce or recreate or learn something about SARS-CoV-2 or COVID-19 induced thrombosis. So what we are learning now, and this is unpublished data, and we have confirmed this by 2 independent scientists within my lab, and we also saw a poster by Dr. Chris Hughes' lab yesterday that actually shows pretty much the same data that we are seeing, which is that ACE2, which is a key receptor of the coronavirus, which has been reported to be largely absent in the endothelial cells in a variety of literature that you see, indeed is actually not absent, but it depends on the hemodynamics. So what we see is that if you expose endothelial cells to variable shear stresses, then there is a critical shear stress after which ACE2 expression actually starts going up. So the controversy whether the virus directly creates endotheliopathy and blood clotting, or is it through inflammatory response, okay, can be resolved with the vein chip. We hypothesize that in addition to the cytokine storm that occurs due to COVID-19, and that could also result in endotheliopathy, the SARS-CoV-2 virus can directly infect the endothelial cells at sites where hemodynamics are compromised. Okay, so we have started to see that ACE2 expression actually goes up due to hemodynamics and high shear stress. And we have also confirmed with our collaborators who's at NEIDL at BU, who has actually shown that when you expose the vein chip or a vessel chip at high shear stress, indeed a virus starts getting inside the endothelial cells directly and starts replicating. So we have started to see actual replication of a living COVID-19 virus within the endothelial cells. Okay, so the work is ongoing, and we expect to test this hypothesis even further as we move along with the vein chip. So this is what we are doing, and this is how this platform is contributing to COVID-19 induced thrombosis. By the way, these experiments which we are doing with the living virus are being done in BSL-3 facility, and what we have learned is that it is much, much easier to work with organ on chips in these high contained facilities than to work with mouse models. In fact, it is just a very, very long path to be doing those kind of studies in BSL-3 facilities, whereas it took us only 3 months of approval time to bring these chips again. So again, the value of MPS systems cannot be understated. All right, so these are some other experiments that we are doing, what we are learning from the vein chip. What we are also learning is that, in fact, the fact that the 95% of human veins are actually microfluidic in nature. What we are also learning is that within these microfluidic veins, it is very difficult to create hypoxia. And the dogma is that when you have clotting, there is essentially hypoxia. So hypoxia is one of the main features that supports thrombosis. It may be in arteries, but in small veins, we do not see hypoxia. You see DVT, but it's not hypoxia. So why is thrombosis still going on despite the tissue not being hypoxic? As I showed you, it may be due to flow or a combination of flow and architecture. So again, within the vein chip, we are starting to learn new things or predict new things or new mechanisms of thrombosis. We can do a very good pathological dissection with the vein chip. So we can do SEM, and you can see fibrin-rich clots in even leukocytes within the cusp. So a lot of the post-analytics of the vein chip is possible, and thrombosis is possible with the platform. And lastly, we have started to work on the muscle function as well. So we are working with a biomaterial scientist, and you can see we can start to look at pumping, actual living pumping with the vein chip as well. This work is also ongoing, and we have just preliminary data, which you can see in this video. We can also start introducing pulsatile flow in the platform. Okay. So I'm going to stop here. This is an old picture. My entire team is here. I've been posting regular updates on LinkedIn and Twitter these days. I've been very excited to see a lot of my old colleagues from the Wyss Institute, and we have had a really good time. I really look forward to attending this conference in the forthcoming years. Thank you very much.